Thanks for this great lecture. I have a couple of points that
Sure.
that I anticipate may be more a matter of discussion rather than facts. The first one is how you deal with the assessment of variant allele frequency in clinical practice, and what do you think it might be if actually impact right now on clinical decision? And the second question is, since we know that these mutations may appear, may fluctuate, may increase over time, is there any suggestion that could be made in terms of time interval where to check again these mutations if they have to be checked again?
Yeah, these are very good questions. So the first question in regards to the variant allele frequency in clinic, I think the impact in clinic is not so high currently because I think we have a lack of really good treatments that can effectively decrease allelic burden. So that's something I completely agree with you. So that we know maybe that a high variant allele frequency is a certain risk for a patient, but right now there is no treatment decision that we maybe only do in regard to that measurement. And regarding the second question, I think that's aiming on patients with clonal hematopoiesis. And this is really interesting, especially because we have mouse models where we can really go to model now clonal hematopoiesis. So starting from a few mutant stem cells and then looking over time how these mice develop MPN. So, and we can now try to model that. And I think what we learn is that these small variant allele frequencies in patients with clonal hematopoiesis, maybe they do not really matter. So it's same like for, as you presented in your amazing talk, single hit TP53 patients. So we have patients that have over a very long period of time, a single hit TP53 mutation, and it's not expanding overall. And these smaller fluctuations, we are not so scared about, but we are very sure that over time, whatever happens, there will be one event, let it be a factor like infections or irradiation or a factor that we don't know, that then kind of promotes this clone over a certain threshold where you kind of cannot stop the expansion to a level where we would call it MPN disease. So I think in the sense of clonal hematopoiesis, the variant allele frequency is not is maybe not so important as we think of right now.
Thanks a lot.
You're welcome.
May I ask you what is the reason why you didn't mention the neutrophil to lymphocyte ratio that is a biomarker very used now in MPNs?
You're completely right. Please don't blame me for that. I neglected a lot of potential biomarkers that are still in the literature. It was just I wanted to have a really good discussion and just mix it with newer, so very established biomarkers and biomarkers we are interested in the future. And that's something I did not mention, but we use in clinic. You're completely right. Yes.
Thank you.
Great talk. Thanks a lot. Following up on the discussion started by Alessandro about variant allele frequency. So I think it would be nice to get some more feeling about what do we do if there's a steady but slow but steady increase in variant allele frequency. Sometimes that happens. Typically, they remain very stable. And of course, during interferon treatments, we like to see the variant allele frequency go down. But what do we do if only without anything else changing? I have a patient, for example, starting out with 58% of CALR and then increasing towards 90% over a course of 2 or 3 years. It kind of makes me nervous, but of course, I don't know when do I really start to check the bone marrow again, or what do I do if nothing else changes? So maybe we can discuss such cases.
I completely agree. So, and even in the sense of clonal hematopoiesis, you want to get rid of the mutation. I think we all agree on that, right? So if there is a possibility to completely remove a CALR or JAK2 mutation to target these cells, I think that's what we should strive for. But in regard to the clinical case that you mentioned, there's a patient where you have an increase in the variant allele frequency. I would also get the gut feeling that something is going on, and I like to react. But to my knowledge, I think there is not a real good evidence-based publication that kind of gives us a guidance how to deal in that situation. But I'm very happy to hear other opinions from clinicians how they would deal in such a scenario.